So viral uveitis, the first one is uveitis in human immune deficiency virus infection, HIV infection. HIV virus infection, acquired immune deficiency syndrome. So HIV AIDS is transmitted by unprotected sexual intercourse and via contaminated blood or needles and vertically from mother to child spontaneous transplacentally during birth or breastfeeding. The HIV depletes CD4 plus T cells. These CD4 plus T cells are vital to the initiation of the immune response to pathogens. Although there is currently no cure or vaccine, the progression of disease can be slowed radically by combination drug therapy. These drugs are antiretroviral therapy (ART). ART is now recommended for all HIV positive individuals irrespective of the CD4 T cell count. Prophylaxis against opportunistic infection may also be instituted. Systemic features, the stages of infection. Initially, there is a flu-like illness which may occur 2 to 4 weeks after infection, sometimes including a rash. Then the clinical latency, it is a predominantly asymptomatic period of several years, about 8 years, sometimes with minor clinical features such as persistent generalized lymphadenopathy. And then the AIDS develops in about half of HIV positive individuals within 10 years and is defined as HIV infection with either a CD4 T count less than 200 cells per microliter or the development of one or more of AIDS defining conditions. AIDS defining clinical conditions include particular opportunistic infections such as respiratory or esophageal candidiasis, infections such as respiratory or esophageal candidiasis, also pneumocystis cerevisiae pneumonia, cryptosporidiosis and cytomegalovirus retinitis. So these are the opportunistic infections. Specific tumors including Kaposi sarcoma which can be seen in this picture, and certain lymphomas and other manifestations such as HIV wasting syndrome, this is HIV wasting syndrome, and progressive multifocal leukoencephalopathy. The ocular features, the HIV can affect any organ of any part of the eyes. In the eyelid it can cause blepharitis, Kaposi sarcoma, multiple molluscum lesions, and herpes zoster ophthalmicus. This is herpes zoster ophthalmicus. This is Kaposi sarcoma. These are multiple molluscum lesions. In the conjunctiva it can cause Kaposi sarcoma, squamous cell carcinoma, and microvasculopathy in up to 80%. These are microvasculopathy. This is conjunctival squamous cell carcinoma, occur in HIV patients. In the orbit it can cause cellulitis, for example aspergillosis, contiguous sinus infection, B-cell lymphoma. In the cornea it can cause keratoconjunctivitis sicca and infectious keratitis, increased incidence of keratitis like herpes simplex, herpes zoster, and fungal keratitis. It can also cause anterior uveitis associated with ocular infections or with drug toxicity like rifabutin and cidofovir. HIV-related retinal microangiopathy. Retinal microangiopathy is the most frequent retinopathy in patients with AIDS developing in up to 70% of patients. It is associated with a declining CD4 plus T cell count and a higher plasma HIV RNA levels, and is marker for increased cytomegalovirus retinitis risk. Postulated causes include immune complex deposition, HIV infection of the retinal vascular endothelium, and abnormalities of the flow. It manifests with cotton wool spots and or retinal hemorrhages, as you can see in these pictures, and sometimes capillary abnormalities such as microaneurysms. In contrast to CMV retinitis, lesions are usually asymptomatic and almost invariably disappear spontaneously after several weeks. Other viral retinitis like cytomegaloretinitis, which is most common, progressive retinal necrosis, acute retinal necrosis can occur. Protozoal such as Toxoplasma retinochoroiditis upon atypical, fungal like Pneumocystis choroiditis, Histoplasma chorioretinitis can occur in HIV patients, like also Cryptococcal choroiditis and Candidiasis. Bacterial infection like syphilis and tuberculosis can occur. Neoplastic like B-cell intraocular lymphoma. Neuroophthalmological, usually secondary to meningitis or encephalopathy due to an opportunistic infection like toxoplasmosis, cryptococcosis, and neurosyphilis, and neoplastic processes like CNS lymphoma can occur. Next is cytomegalovirus retinitis. Infection with CMV herpes virus is very common in the general population, causing no or minimal constitutional symptoms in most healthy individuals. CMV retinitis is seen in patients immunocompromised from a variety of causes. It is common opportunistic ocular infection in patients with AIDS, in whom it may represent reactivation of latent infection. Without treatment, severe visual loss is essentially inevitable. Since the advent of ART, the incidence and severity have declined, though the prevalence remains high, partly due to increasing survival rates in AIDS patients in whom systemic steroid therapy may be a risk factor. There is a very strong association with a low CD4 count. Systemic features: severe involvement of a range of organs including the lungs, CNS, and skin can occur in the immunocompromised. Ocular features: the presentation is with reduced vision from macular involvement or with floaters from vitritis. One eye is usually affected, initially progressing to the both eyes in 50% of patients if untreated. Indolent retinitis, which we will discuss, frequently starts in the periphery without symptoms and progress over weeks. Anterior uveitis can occur but is usually mild with little no injection. Cataract is common. Vitritis typically mild. Retinitis, the characteristic appearance is one or two areas of dense white retinal infiltration, associated prominently with flame-shaped retinal hemorrhages like pizza pie or margherita pizza. Appearance beginning peripherally, centrally in 10% only, and extending along the course of the vascular arcades. Peripheral areas tend to appear granular with fewer rounder hemorrhages and little vasculitis. Indolent, which is more peripheral and less aggressive, and fulminant clinical patterns have been distinguished. The visual acuity can be significantly reduced if the macula is involved. Optic neuritis may result from direct spread or from primary involvement. Retinal necrosis is evident in areas where active inflammation is settled, leaving irregular pigmentation, atrophy, holes, frequently leading to retinal detachment. A major cause of visual morbidity in 50% patient. Frosted branch uveitis (FBA) describes marked vascular sheeting and that occurs in 6%. This appearance is seen in other conditions, and the term is also used for a distinct idiopathic disorder. Immune recovery uveitis, cause of limited visual outcome in CMV patient, thought to be due to a regenerated immune response against residual viral antigens following immune reconstitution with ART therapy. Manifestation can be severe progressive to phthisis in some cases. Treatment, close liaison with an infectious disease physician is critical. ART is the mainstay of management, restoring patients' innate ability to suppress CMV activity. Discontinuation of antiviral treatment is considered when the CD4 count reaches more than 100 to 150 cells. Valganciclovir is prodrug of ganciclovir. It is taken orally and is effective for both induction. For induction, 900 mg twice daily for up to 3 weeks. In maintenance, 900 mg daily. Neutropenia is a common side effect due to bone marrow suppression, but can be effectively treated with filgrastim, which is a granulocyte colony stimulating factor. Ganciclovir, foscarnet, pseudofovir given intravenously were formerly key therapeutic agents, but substantial side effects have largely led to their relegation to reserve status. Ganciclovir slow-release intravitreal implant is shown in this picture. So this is now less commonly used, but still has utility in situations such as intolerance of systemic treatment. Effective is intravenous therapy. Duration of efficacy is 8 months. Intravitreal injection of other agents such as fomivaricin and cidofovir may occasionally be indicated. Vitrectomy with endolaser demarcation and silicone oil tamponade is successful in around 75% of CMV related retinal detachments. Steroids may be required for IRU, immune recovery uveitis, though intravitreal and systemic administration should be used with caution. Prognosis is poor despite treatment if the macula is involved. Screening a patient with low CD4 count, 3 monthly less than 50, 6 monthly 50 to 100, yearly if more than 100 microliter. Progressive retinal necrosis, also known as progressive or posterior outer retinal necrosis. Posterior outer retinal necrosis. Posterior outer retinal necrosis is a rare but devastating form of necrotizing retinitis, which is usually caused by varicella zoster virus and possibly other herpes virus. It occurs predominantly in patients with AIDS, but may be associated with other immunocompromised states, particularly the drug-induced. The prognosis is extremely poor. With no perception of light, the outcome in more than half of affected eyes. Ocular feature presentation is with rapidly progressive unilateral or bilateral visual loss. Anterior uveitis and vitritis are minimal in contrast to CMV retinitis and acute retinal necrosis. In retinitis, there are 3 stages: the early stage, established or middle stage, and late stage. The early stage, multifocal, homogeneous, yellow-white, deep retinal infiltrates. The macula may be involved at an early stage, often giving a cherry red spot. In established or middle stage, the signs typically spread rapidly around the retina with very extensive full-thickness necrosis. Signs of vasculitis are absent or mild, and significant hemorrhage is uncommon. As inflammation clears, perivenular translucency is seen. The late stage rheumatogenic retinal detachment is common, as is optic atrophy. Investigations: vitreous aqueous PCR assay for viral DNA antibody assay is less effective. Treatment: immune rescue with ART together with aggressive antiviral therapy. Intravitreal, intravenous ganciclovir, foscarnet, and vitreoretinal surgery for retinal detachment. So, after treatment, there is aggression of lesions and retinal atrophy. Next topic is acute retinal necrosis. It is rare but devastating necrotizing retinitis. It typically affects otherwise healthy individuals and tends to be caused by herpes simplex virus in younger and varicella zoster virus in older patients. Other herpes viruses are also suspected. The prognosis is relatively poor, with more than half of patients eventually achieving only 6/60 as a result of retinal and optic nerve ischemia or RRD. Systemic features: the systemic features have been reported. ARN has been reported following and occurring simultaneously with HSV encephalitis and herpetic skin infection. Ocular features: there is initially unilateral with blurred vision, floaters. Pain is usually a feature. The American Uveitis Society criteria for diagnosis is: number 1, prominent anterior uveitis and vitritis. So both combine pain uveitis. Episcleritis and scleritis may occur. The one or more discrete foci of peripheral retinal necrosis. Peripheral retinal necrosis: deep yellow-white infiltrates. So these are deep yellow-white infiltrates. Deep yellow-white infiltrates with well-defined borders are seen. They have well-defined borders. Retinal hemorrhages can occur but are generally less prominent than in CMV retinitis. So retinal hemorrhages are less prominent. The acute lesion resolves after 6 to 12 weeks, leaving behind necrotic retina with hyperpigmented borders. With hyperpigmented borders as seen in this picture. Full thickness retinal necrosis. Secondary RRD is a major cause of visual morbidity. Next is circumferential spread of retinal involvement. Posterior pole involvement is late. Posterior pole involvement is late. Optic neuritis is sometimes a feature. Fourth point is occlusive retinal vasculitis, including arthritis. Pre-retinal neovascularization can develop, may lead to vitreous hemorrhage. Rapid progression of disease in the absence of treatment. Investigation: vitreous aqueous PCR for viral DNA antibody assay is less effective. Treatment is with acyclovir intravenously 15 mg per kg every 8 hours for 10 to 14 days. Then orally 800 mg 5 times daily for 6 to 12 weeks. May hasten resolution of the acute retinal lesions, dramatically reduce the risk of second eye involvement. Long-term therapy is occasionally required. Oral valacyclovir, famciclovir may be substituted for oral acyclovir with similar outcome but better tolerability. Valacyclovir 2 gram orally 3 times daily can be used as an induction dose, followed by a maintenance dose of 1 gram orally 3 times daily. Intravitreal ganciclovir foscarnet may improve the prognosis. Systemic steroid may be started 24 hours after the initiation of antiviral therapy, especially in severe cases. Laser retinopexy around necrotic areas has been used in the past but has no effect on the retinal detachment rate and should be avoided. Vitrectomy for RRD, commonly with siliconyl template. Herpes simplex anterior uveitis. The herpes simplex anterior uveitis may occur with or without active corneal disease. So, patchy and occasionally sectoral iris atrophy that includes the pigment epithelium. This is occurred in herpes simplex anterior uveitis. This is common, as is elevated IOP is common. The pupil may be larger than its fellow. As in Fuchs uveitis syndrome, the capes may be fine, stellate, and diffusely distributed across the cornea, but can also be large in group. There is often a past history of herpes simplex keratitis, cold sores, and sometimes genital herpes. Recurrent episodes of herpetic iritis involve the same eye in almost all patients. Distinguishes herpetic from cytomegaloiridocyclitis can be difficult. Treatment is with topical steroids. Prednisolone acetate 1% 4 times daily. Topical cycloplegic and topical cycloplegic in combination with oral antiviral acyclovir 400 mg 5 times a day. Famciclovir, valacyclovir is better tolerated. Steroids may be delayed. Use with caution if active epithelial disease is present. When a topical antiviral may be added, raise IUPs treated as necessary. Varicella zoster virus anterior uveitis. This is of variable severity. Occurs in around 50% of patients with herpes zoster ophthalmicus. Starts 1 to 3 weeks after the acute skin rash. Occasionally in patients with HZO without dermatitis. Zoster sign herpet. Zoster associated iridocyclitis may be recurrent when diagnosis is usually straightforward due to a past history of ipsilateral HZO. As with herpes simplex, signs may be granulomatous inflammation. Sectoral iris atrophy is often present. Corneal sensation reduced, IOP raised. PCR analysis of aqueous is indicated exceptionally. Anterior segment inflammation can occur in primary VZV infection in chickenpox, particularly in the immunocompromised. Neuroretinitis is rare. Uveitis has been reported following VZV vaccination. Topical steroids and mydriatics as the treatment, in addition to standard systemic antiviral treatment for shingles. Systemic steroids are required rarely for optic neuritis. Like all patients with HZO must be monitored by an ophthalmologist, depend on severity, up to weekly for at least 6 weeks to detect ocular inflammation. Subsequently, possibly long-term to detect late complications. Persistence or recurrence of anterior uveitis may respond to a weekly long course of acyclovir 800 mg 5 times a day, and long-term systemic antiviral prophylactic treatment may be considered for repeated recurrence. VZV vaccination offers protection against shingles. Cytomegalovirus anterior uveitis, iridocyclitis in the immunocompetent is more common than previously realized, albeit still less prevalent than HSV VZV related inflammation. It may be recurrent or chronic and unilateral or bilateral. Elevated IUP is there. CMV is reported as a cause of Posner-Schwarzman syndrome. Little or no ciliary injection, limited flare, few cils, corneal endothelitis. KP of a range of morphology and sectoral iris atrophy. PS are rare. A key diagnostic indicator in some cases only may be a failure to respond to acyclovir and or steroids. PCR antibody assay of an aqueous sample should be considered if there is clinical suspicion. Oral veil gain cyclovir in proven infection, which sometimes require long-term continuation. IUP elevation may be persistent. Rubella, German measles, common childhood infection, follows benign short-lived course, cross-placental transmission of virus to the fetus. From infected mother can lead to congenital abnormalities of multiple organ system with severity generally worse the earlier in gestation infection occurs. Latent rubella virus may cause CAU relatively. Chronic anterior uveitis, relatively unresponsive to steroids, has been implicated in the causation of FUS. Ocular features of congenital rubella include cataract, anterior uveitis, salt and pepper pigmentary retinopathy, glaucoma and microphthalmus. This is rubella retinopathy, salt and pepper appearance, predominantly manifesting in the macula. Also glaucoma, microphthalmus. Measles, congenital infection with the measles virus can cause spontaneous abortion and or congenital systemic and ocular anomalies including cataract and retinopathy. Infection acquired in childhood typically feature conjunctivitis and epithelial keratitis. Occasionally retinitis with macular and disc edema can occur. Subacute sclerosing pain and encephalitis is a late complication of measles infection, manifesting with chronic progressive neurodegenerative and usually fatal disease of childhood caused by measles virus. Posterior uveitis is common, may presenting feature. This is retinal involvement in subacute sclerosing pain and encephalitis. Zika virus is transmitted by an infected Aedes mosquito. Virus can be passed from pregnant woman to her fetus, resulting in significant birth defects, including microcephaly. Congenital Zika ocular defects include chorioretinal and macular atrophy, focal pigmentary changes in the macular region, optic nerve abnormalities, glaucoma. Adult with acute infection, conjunctivitis is the most common, followed by uveitis. The virus may persist in the lacrimal glands, other tissues of the eye, particularly in the retinal pigment epithelium. Ebola virus, responsible for epidemic in West Africa, has the potential to cause clinical features in sporadic outbreaks. In survivor, post-Ebola virus disease syndrome may result in ocular disease, arthritis, hearing loss, abdominal pain, neuropsychotic disorder. Uveitis occurs in up to 1/3 of survivors. May result in acute chronic visual loss. Anterior posterior pain uveitis, most cases occurring within 2 months of discharge. 50% subsequently develop cataract. Optic nerve swelling has been reported. Virus has been detected in the aqueous in the acute situation, can infect and persist in the retinal pigment epithelial cells. Treatment is topical oral corticosteroids and need to be started at the onset of symptoms to prevent long-term visual loss.